Hi, good morning, everyone. My name is Mayra Gonzalez, and I chose ventilator-associated pneumonia. My evidence-based practice proposal is using VAP bundles to reduce the patient's risk and improve patient quality of care. Now, the reason why I did choose my topic as ventilator-associated pneumonia, or VAP for short, is because, as we all know, we're all moving into the field very, very soon, and I do plan to go into the ICU. And unfortunately, VAP is a huge epidemic on the ICU floors. So this is why it caught my attention. Significance of the problem. Ventilator-associated pneumonia, or VAP for short, is a significant health issue that affects ICU patients on mechanical ventilation. VAP develops when bacteria or viruses penetrate the lungs, causing inflammation and serious consequences that prolong hospital stays and increase death rates. Reports. The CDC has reported that VAP is the most frequent healthcare-associated infection in intensive care units, or ICUs, affecting 8 to 28% of mechanically ventilated patients. VAP causes prolonged ICU stays, increased mortality rates, and high healthcare costs. Solutions. We will go into solutions a little bit in more detail as the presentation progresses. So, solutions. VAP incidents and complications can be significantly reduced by using evidence-based VAP prevention interventions like VAP prevention bundles. The bundles' multimodal approach to VAP risk factors and preventions have shown promising results in the past. For my EBP project question, in adult patients receiving mechanical ventilation in the intensive care units, how does the implementation of an evidence-based VAP prevention bundle compared to standard care practices affect incidence of VAP and patient outcomes such as length of ICU stay and mortality rates in a time period of over 6 months? So for the theory, I did decide to go with Kurt Lewin's change theory. It is a very popular approach for understanding and managing planned organizational change. So Lewin's change theory goes by 3 easy steps: unfreeze, change, and refreeze. Unfreezing requires awareness of change and breaking down old habits and attitudes. The shifting stage consists of changing practices and processes, while the last stage, refreezing, hardens the altercations and making it a new norm. So I thought that this would be the easiest, most practical, efficient theory to go with, as we would like to take down old policies and procedures and put on new protocols and policies and procedures. So, review of literature. So the databases that I did use was PubMed, CINAHL, Scopus, and Cochrane Library. Reasons for choosing these databases was because they encompass healthcare literature, particularly critical care and infection prevention. Keywords that I did use were infection control, VAP prevention, evidence-based practice, ICU prevention, and ventilator-associated pneumonia, plan change theory, and Lewin's change theory, and lastly, patient safety. Emphasis on up-to-date and significant research articles to inform the intended change project. Summary of evidence. The literature evaluation comprised quantitative and qualitative investigations. Let's take a look at the quantitative first. Quantitative studies examined the effects of treatment on VAP incidents using experimental, quasi-experimental, and retrospective cohort designs. These designs help studies link interventions to VAP results, while qualitative research studies use interviews, focus groups, content analysis, and examine healthcare practitioners' VAP preventative and plan change experiences. This qualitative research illuminated the challenges of integrating evidence-based practices and clinical change acceptance. The literature examined many VAP preventative interventions. Oral care methods, head-of-the-bed elevation, ventilator bundles, ventilator-associated event reduction techniques were implemented. Infection control and respiratory care were used in the intervention bundles to also lower the risk of VAP. Additionally, studies use different size and characteristic samples. For example, some research focused on single ICU or specific patient demographics, while other studies use bigger multi-center samples for generalizability and statistical power. Researchers selected mechanically ventilated intensive care unit patients based on age, underlying diseases, mechanical ventilation time. Due to sample variances, research tested therapies in varied patient population and clinical settings. Recommended best practice. So according to literature review, prevention bundles is the optimal strategy. Several studies have shown bundled therapies to reduce VAP incidence and improvement in patient outcomes. Researchers have stressed that evidence-based clinical practice guidelines for VAP recommended oral care procedures, head of the bed elevation, and spontaneous breathing trials are emphasized in VAP prevention guidelines. Components of the bundled included oral chlorhexidine, subglottic suctioning, and ventilator circuit adjustments. I just wanted to show you guys this diagram. I know it's a little bit outdated from 2015 to 2017, but this just shows the consistency of the effects of a VAP bundle. So they took 131 subjects, patients, and in both scenarios, pre-bundle and post-bundle, the evidence shows that patients who were taken care of with a VAP bundle were 65 to 69% less likely to develop VAP. Policies and protocols. The policy implementation compromises teaching and training healthcare providers on VAP prevention and evidence-based procedures. Monitoring system track bundles intervention compliance and evaluates the intended changes, influence on VAP rates and patient safety. This policy is projected to minimize VAP incidence, ICU time, and patient outcomes, creating a safer and more effective healthcare environment. The VAP preventative project policy also includes evidence-based interventions targeting VAP risk factors. Plan of action. So first, deploy a bundled VAP prevention, advocating incorporating evidence-based therapy to minimize VAP risk factors. Oral chlorhexidine, head of the bed elevation, and ventilator circuit changes may help. Education, training are very crucial. This strategy trains healthcare practitioners and VAP prevention evidence-based strategies. Workshop, education, and VAP reduction awareness are essential. Implementation plan. So from my implementation plan, I do have 6 steps. Step number 1 being the introduction and planning. So for introduction and planning, we would form a multidisciplinary team to administer the VAP and prevention bundle. This team will manage implementation and stakeholder collaboration. A comprehensive needs assessment will reveal VAP prevention measures and gaps during planning. Implementation goals will include VAP reduction and patient outcomes. A timeline will allow for planning, training, and monitoring. Step number 2, educating and training. The implementation plan must educate and teach all relevant healthcare workers who cares for mechanically ventilated patients. Educational materials and staff training will introduce VAP prevention bundles, evidence-based strategies, and each bundle component and its reasoning will be stressed in training. Step number 3 is protocol development and standardization. The implementation strategy will establish and standardize protocols and standards for each VAP prevention bundle. These protocols will detail dental care, head of the bed elevation, ventilator circuit modification, to name a few. Standardizing methods will assure consistency in healthcare facilities. The hospital policies and procedures will incorporate these measures into the ICU daily operations. Monitoring and evaluation. A thorough monitoring and evaluation system will track VAP prevention bundle effectiveness. Infection control and ICU professionals will gather and analyze the data. Data will be examined to measure VAP reduction progress and bundle intervention compliance. The monitoring system will uncover issues and enable a prompt intervention and revision to the implementation plan. quality improvement and feedback is our last step. So the multidisciplinary team will meet regularly and review the results. And these meetings will foster teamwork, feedback, and communication, discuss challenges, triumphs, and place for development. Feedback from all team members can assist in improving the implementation process. So if you take a step back, all we are doing is literally creating a team for this prevention bundle. We're educating our team, all of our nurses, our doctors, respiratory therapists. Then we're developing and standardizing protocol. We need to have rules in place. Then we're monitoring and evaluating. We're having professionals gather all the data. And lastly, it is a quality improvement and feedback. This is when everyone comes together and we discuss the progress of this of the project. Evaluation plan. So primary outcome of measures is VAP incident rates per 1,000 ventilator days per patient. Secondary success measure will be the interventions. Frequent audits and documentation checks will collect the data for us. Quality improvement sessions and performance reviews will give staff input. Staff meetings will deliver VAP bundle incident compliance data. Evaluation plan continued. Staff and implementation observations will identify change facilitators. Any implementation issues, change resistance, or resource limits will be highlighted as a change inhibitor. Alternative options may include improving education, training, modifying package components based on the feedback, investigating alternative compliance tactics, and practicality, evidence-based support, and possible impact for VAP prevention will determine alternative consequences for future use.
About ventilator-associated pneumonia, commonly referred as VAP. Ventilator is a device that supports the process of breathing by pumping air into the lungs of a patient who cannot breathe naturally. What is pneumonia? Pneumonia is an infection that inflames the air sacs in one or both the lungs, and the air sacs may fill with either fluid or pus. Here is a picture which describes the difference between a healthy lung and a lung affected with pneumonia. When we see the left lung, which is healthy, the picture of alveoli shows how a healthy alveoli looks. On the other hand, the right lung, which is affected with pneumonia, we can see the picture of alveoli, which is inflamed and filled with fluid or pus. Now, the common risk factors for developing ventilator-associated pneumonia are elderly people, malnutrition, underlying lung disease, artificial airway or nasogastric tube, colonization of dental plaque with respiratory pathogens, bacterial colonization of the oropharyngeal area, aspiration of subglottic secretions, head of bed either less than 30 degrees or after surgery. Ventilator-associated pneumonia includes tachypnea, tachycardia, fever above 100 degrees Fahrenheit, increased WBC count, increased purulent tracheal secretions, crackles in lungs, worsening oxygenation, hypoxemia, and PF ratio changes. Now, how is VAP diagnosed? Through chest X-ray, which shows new or persistent infiltrate, cultures like tracheal aspirate and blood cultures, CPIS, that is clinical pulmonary infection score, which is above 6, bronchoscopy or bronchoalveolar lavage. VAP bundle is followed for preventing ventilator-associated pneumonia. VAP bundle is a set of evidence-based interventions related to disease process that, when executed together, results in better outcomes than when implemented individually. Now, here are some evidence-based practices to prevent ventilator-associated pneumonia. First comes hand hygiene, using gloves appropriately. Next is semi-recumbent positioning, that is head and elevated 30 to 45 degree unless contraindicated. Next comes oral hygiene with 0.2% chlorhexidine. Oral hygiene should be done in every shift in order to prevent aspiration of oral secretions.
Thank you. Thank you for your time. And these are my references.